When we talk about improving health access and outcomes, rural America presents a unique and deeply complex challenge for state leaders. In these communities, a patient's care journey is rarely a straight line. Instead, it's often disrupted by workforce shortages, transportation gaps, outdated and incomplete records, and the difficulty of simply staying in contact with transient populations. But a massive shift is officially underway. With the federal government's recently enacted $50 billion Rural Health Transformation Program, moving from funding to true community impact, however, it takes more than just checking a compliance box. It demands a flawless and robust identity foundation, one that bridges fragmented data silos, powers effective outreach, safeguards identity privacy, and gives rural populations the dignity and attention they deserve. I'm Wyatt Cash with Scoop News Group, and joining me to map out this foundation for rural health transformation are Melissa Magstadt, Secretary of Health for the state of South Dakota, and Deepika Hammer, Director, Market Planning, Government Healthcare Solutions at LexisNexis Risk Solutions. Melissa and Deepika, thank you so much for joining us. And Melissa, I'd like to start with you. States are beginning to move from planning to implementation around rural health transformation. From your perspective, what makes this moment especially important for state health leaders, and what are the biggest needs that you're seeing across rural communities?
It's a great question. I think any of us have worked in healthcare for any length of time has seen the healthcare system under more and more stress. Workforce shortages, certainly gaps in access to care. I think about disparities in healthcare outcomes from one population to another. So we saw these things coming, but unless there's that infrastructure rebuild that we're needing to lift up that healthcare system, it was on a trajectory that was just not sustainable. And I do appreciate Congress looking at this and making this once in a lifetime investment into healthcare that we're needing. And I think the word transformation with these funds is really the key. This is not about propping up a system that is under a lot of pressure and it's not going the right direction. It's on a trajectory that is not sustainable. Transformation to repivot us to with one-time investment monies to have a different trajectory, just a little bit of a different trajectory. And what I figured out in the state of South Dakota is that there's not a shortage of great ideas, innovative ideas, but all great ideas needed an influx of one-time infrastructure cash, whether it's technology investment, whether it's infrastructure system building, all of these require that one-time dollars for transformation. And so I know everyone in my states and our colleagues are very excited for healthcare to be able to have this one-time infusion of dollars to benefit each one of our citizens, especially in rural. And part of my counties, 30 of them at least, are considered frontier counties.
So, Deepika, I think as we talk to health officials, one of the things that we're really hearing, particularly when it comes to rural health transformation, that it starts with understanding the patient, not just as a record in one system, but as a whole person with changing needs. I wonder, why is that full view so important as you see it for states, and why is that critical as they think about their investment strategies?
Thanks, Wyatt. That's a great question. And I'm really excited to be here with Melissa to talk about this today. So thank you for the opportunity. When we talk about rural health transformation, it's important to recognize that a medical record is an important part of the story, but only a sliver and a part of the story about an individual. So it tells us what happens when someone interacted with the healthcare system, but it might not necessarily tell that whole story around what's preventing them, for example, from accessing care in the future. We've seen that in many rural communities, health outcomes are shaped by a variety of factors like access to transportation, provider shortages, distance to care, economic pressures, connectivity, and changing life circumstances. And so those realities can have just as much of an impact on health outcomes as can a clinical diagnosis or a treatment plan. And that's why states need to think beyond individual records and towards a more complete understanding of the people and the communities that they're serving. Information about a person often exists across multiple programs, multiple databases, organizations, providers. And when those pieces remain disconnected, it becomes harder to understand the holistic needs of an individual and to be able to effectively coordinate services and measure outcomes. And so at Lexis, we've seen with the thousands of government health partners that we work with that a strong identity and data foundation really helps state and local agencies be able to responsibly connect those fragmented views so that they can better identify those barriers, target these resources, and understand which communities need the most support.
So, Melissa, from a practical level, many of the health systems in many states are working with disconnected records, limited interoperability, incomplete views of the populations they serve. Tell us how does that fragmented data affect the state's ability to design programs and coordinate care, as well as to really understand where resources are most needed?
That's a really interesting question because, in ways that most people might not think about. So even in the transferring of data regarding, let's just take it down to the patient level. If a piece of information is not communicated from one health system or one provider to another, that is a very critical piece, certainly patient outcomes, whether that even be negative patient outcomes, or there are times that we've seen in our data where patient loss of life has happened from a lack of transferring a critical piece of information from one healthcare provider to another. And that shows up in some of our patient outcome data. But then we take that aperture and expand it a little bit to what Deepika was just talking about, that, if you do not have data and you don't have a picture of what you're looking at, where do you know you're falling down? Where's the place that people are suffering more? Where are the disparate populations? Where do we put our resources? Where are the levers that could be pulled in certain populations for impact? In the state of South Dakota, 64 out of 66 counties are considered rural. A little over 30 are considered frontier. But we're also privileged to have 9 tribal sovereign nations in the state of South Dakota. And so our counties can look very different in the same region, depending if they are tribal counties or not tribal counties. And if you were to look at our data and we parcel that out, certainly our rural communities and counties have worse outcomes, disparate outcomes than our urban. But you take it into tribal rural, and those citizens in that area, even more so disparate outcomes than even rural areas. And so how we use our data is really, as was said before, to try to understand the population, where are the outcome disparities, and how to dial in resources. Now, I also have a very practical reason for me wanting to use data as well. As the Department of Health gathers an enormous amount of data about the state of South Dakota. It is not the department's data, it is the citizens' data. But for us to bring back reports and bring information back out to the community and the citizens to use, there's 2 things. It's labor intensive if we're creating a report. And the minute you create a report, it's already aging. It's already old. Yesterday it became old. And so how do we give data to the citizens for them to use that is current, updated, and it's always adding the most new data to the mix, to the picture? And the next step is, how do we take that down to the county level? So it's not, Melissa, about resources. Where do I put resources? But where do local organizations, where do local critical access hospitals, where can they put resources? Because they understand their local data well enough to be able to make some of those decisions too. We're not at that point right now, but one of the key pieces that we're using for our rural health transformation funds is to take all of our data, put it into a data atlas, drive it all the way down to being able to understand your county or community data so that local decisions could be made as well. So we're using these dollars at that one-time investment into that type of capability for a state, because one county can have a completely different set of outcomes than the other. For instance, in South Dakota, if you were a white South Dakotan, we lose 50% of our white South Dakotans by age 80. we lose 50% of our Native American South Dakotans by age 58. It's a 22-year discrepancy between people who could literally live in the same county, one next to another. And so those disparities become very real in the state that I live in, especially when we start reporting out disease or mortality data. So county level data is an important thing for us to understand and be able to give to the citizens their data in that kind of granular level.
Those are some really insightful points. And I love the way you express the importance of giving the data into the hands of counties and officials locally to make better on the ground decisions and how important that is. Well, speaking of data, Deepika, I'd like to just kind of get your sense too as what are some of the data fundamentals that health offices and rural health teams need to be thinking about as they kind of stand up some of these implementation plans?
Yeah, so one of the biggest risks that I'm seeing as states are now moving into implementation is before. Let me start that over. One of the biggest risks I see is states moving into implementation before establishing a really important and strong data foundation that's needed to make sure the investments are targeted to where they need to go, and that it can be measured over time effectively. So the way that I think about it, I would encourage states to think about five fundamentals. First, clearly define the population that they're trying to serve. Melissa mentioned the nuances within the rural counties within South Dakota, frontier counties, rural counties, and even within rural counties, two counties that are next to each other might be totally different. So first, clearly define the population and the counties that you're trying to serve. We know that not all rural communities are the same, and states need to understand who they're trying to reach, where the greatest needs exist, and then what barriers those populations face. Second, I would say that's important is to establish a trusted identity foundation. The same individual often appears across Medicaid, public health, human services, and provider systems. So if states can't confidently connect those records, care coordination and measurement become much more difficult and really hard to sustain over time. Third, I would say focus on data quality and reachability. These transformational programs are only going to be effective if eligible residents can be identified, they can be contacted, and they can be engaged throughout their healthcare journey. The fourth thing I would say is to make sure that states are developing a clear visibility into their provider landscape. Melissa mentioned earlier workforce shortages and provider availability, and we know that those things can impact access for individuals living in these rural communities. And then finally, I would just make sure the fifth thing I kind of think about when it comes to this is building governance and measurements into the programs from day one. Privacy is incredibly important, obviously, when it comes to all of this healthcare data, but accountability, governance, and performance metrics should all be part of the initial design as they're thinking about implementation and not an afterthought.
So, Melissa, one of the other challenges that we often hear from health officials, particularly at the state and local level, is one of the things that often gets overlooked is outreach. States may design strong programs, but residents still need to know and understand that these programs exist and how to access them and really trust them the way they were intended. What kind of outreach challenges do you face in meeting the rural communities that you were discussing, and how are you thinking about reaching residents more effectively?
That's a great question. We're the public health department. We have to reach the public. But our public is diverse. And so how Melissa in her 50s receives information is different than my grandmother in her 90s would receive information, or my granddaughter, 15 years old receives information. And yet they're all part of the population that needs to receive information about whatever program or whatever risk or whatever information we're trying to place out there. I think one of the things that we're challenged is that we are all in such an information-driven society that it's difficult to get on the radar for people. I was reading this fantastic article, it was called The Capacity Challenge, Humans versus Technology. And in the article, they talked about how we went from consuming about 34 gigabytes of information a day 20 years ago. We're up to 74 gigabytes that you and I absorb day in and day out for information. And they compared that to about 16 movies of gigabyte every day that we're gathering, or 100,000 words, which is like reading The Hobbit every day. That's all of the information that we're doing. And it pointed out in the article, not only were we taking all this information, but we're doing it in layers. So someone might be listening to this, but then they're also working on their computer, and then they're also answering a text. So we are absorbing information in multiple ways. So the old way of the Department of Health is we put it on the website and assumed everyone came to find it. Not so. We've got to hit all multiple layers of the various ways that people consume information. And then, by the way, I've got different populations in my state. My native tribal persons, how they receive information, and they consider it what I would say trustworthy information. So not only information, but where they get trustworthy sources is different than what we have as a Hutterite population. Our Hutterite population, you could maybe compare them to an Amish or a Mennonite, where they're more secluded and less connected to social media. So how I reach that population is not going to be the same as I would reach a 40-year-old that maybe is very much connected. So we do a multiple level of trying to reach multiple levels, multiple ways, multiple times. And I still don't think we do it enough. I still don't think we do it enough, because if anyone said to me about 3 or 4 months after we started talking about rural health transformation funds, when folks came up and asked, well, now what's rural health transformation funds? I don't even know what that is. I'm thinking we still haven't saturated the people. Why? Because we're competing with 100,000 other words that the whole citizenry is taking in and day out. So it's a challenge for us, but it's not about just putting in our website and thinking that people want to come to the Department of Health website and just peruse our website. Oh no. Yes, we put it there, but we've got to push it out in so many different levels, depending on the population we're aiming for. And then we've got to do it over and over and over again. And then, by the way, do it over and over and over again. And, it's a challenge for us, but, I think we've learned a lot through the years as to that just posting it once is not the way to do it, but really using, I would say, the science of communications to tap into that specialty and utilize that group of folks who know how to reach the people we need to reach, and lean into them for their expertise in that as well. So we've done that better through the years. Do we need to do it better? Absolutely. We're competing with 100,000 words a day.
Well, Deepika, I'm curious, how can state and local organizations really make sure that the work that they're doing around this data and technology implementation, that it remains centered on the people, particularly those who have historically been overlooked or underserved?
Yeah, I think the most important principle in kind of thinking through all of this and talking about data and technology is remembering that data represents a person, but it never tells their entire story. Technology and data can certainly help states better understand needs and target resources more effectively, but they should never become the focus. The focus has to remain on improving people's ability to access care, receive services, and achieve better outcomes. And I think that starts with listening to the communities that are being served, rural residents, local providers, and the community organizations that are doing a lot of this heavy lifting of this work, often understand barriers that are not available or visible in administrative data alone. And those perspectives can really help shape how programs are designed and evaluated. I would also say states should also focus on reducing burden. As I'm sure all of us are aware, individuals are often asked to navigate multiple agencies or repeatedly provide the same information again and again because systems don't talk to each other and they don't work well together. Technology should really make those experiences easier, not harder for the individual who's accessing this really important care. And the third thing I would say is that trust matters as well. Residents should understand how their information is being used, how their privacy is being protected, and who might still be missing from the picture. And so even when overall numbers improve, some communities can still continue to face significant barriers or different barriers because not two rural communities are the same. And so I would say at its best, technology can help public servants spend less time navigating fragmented information and more time spending their time helping people, which is what we're all excited about in healthcare and public health. It's the mission, and it's about helping people, making sure that they're getting access to care and that communities are flourishing. And so that's how we keep the rural health transformation centered on dignity, trust, and human outcomes.
And then my last question is for both of you. While funding creates major opportunities, states will also need to show that the resources are being put to good use. So I'll start with you, Melissa. What should states be thinking about now so that 5 years from now, if you will, they can measure whether these investments improved access and quality and the outcomes for rural residents?
Yeah, this particular grant was an interesting infrastructure of the grant itself. It's not like other grants that we've received where it's a 5-year block grant and sort of move the needle for the next 5 years. This grant is structured with yearly demonstrations of progress, yearly demonstrations of outcomes and metrics, all of those things that determine whether the state can apply for that next set of dollars if we accomplish the metrics and the outcomes that we said we were going to in year one. So, as the federal fiscal year ends in the next couple of months, we need to show what we've done for outcomes, metrics, and processes that have moved the needle forward. And so this grant is very unique in that way. So it has us on a very fast pace of getting dollars out, but also building into those grant opportunities that we're making to hospitals and systems and communities, built in the same level of risk, of accountability that's been built into us: outcomes, metrics, and the third one, sustainability. These are one-time dollars. These are not going to be something that'll be 5 years and 5 years and 5 years. These are one-time dollars. And the federal government, and we pass that information on to our grant awardees, that it's about sustainability. So you might have a great plan, but if you don't have a sustainable way of lifting that up when these 5 years are done, those are not eligible funding opportunities. Go back to the drawing board on how you're going to sustain it, because good ideas that don't have a sustainability plan are not eligible and would not be a something that we could help fund. But good plans, good metrics, good outcomes with a built-in sustainability plan, oh, that's a transformative change right there. And we want to partner with those persons bringing those forwards to bring that forward into our state, because we know that that'll be an impact maker for our citizens for the long haul, not just 5 years, but for the long-term trajectory of healthcare.
And Deepika, what would you add to that?
Yeah, I would say if we want to understand whether these investments are improving access, quality, and outcomes, those measurement frameworks that Melissa was mentioning need to be developed from the beginning, starting in year one. So that means starting with a clear baseline of who is being served today, where the barriers exist, and what outcome states are trying to improve. I think there also needs to be a clear communication or connection between the investment being made and the result that the state hopes to achieve. It's not enough to measure activity. We can count programs launched or outreach campaigns conducted, but those metrics alone don't tell us whether people's lives were actually impacted and hopefully improved with this funding. So states should really focus on measures that reflect that real world impact. Are residents being reached effectively? Are they accessing care more consistently? Are more services available? Are outcomes improving? One thing that we've unfortunately seen with federal funding and state funding is making sure that the people who are getting these grants, are they legitimate providers? Are they going to the right place? So making sure that all of that is taken into account, and there's outcomes around making sure that we are good stewards of this very large amount of money, but still a limited amount of money that can only do so much in such a little time frame, making sure that we're all good stewards of these taxpayer dollars and making sure that they're as effective as possible to provide the most impact as possible is really important, so that states can measure change over time and do it in a way where there's a consistent provider identity or a consistent individual identity longitudinally over time to make sure that the impacts are really being measured and then can be compared for future transformational outcomes. And so 5 years from now, we won't be talking about success by talking about how much funding was distributed. We'll be talking about those kind of outcomes that I talked about on whether rural residents are really experiencing better access to care and better outcomes, and whether states can clearly demonstrate that progress.
Well, Melissa Magstadt and Deepika Hammer, thank you so much for sharing your respective perspectives on just the importance of this funding opportunity and ways to make sure it really counts for the citizens, and that their outcomes ultimately are improved because of it. So thank you so much for joining us.
Thank you. Appreciate it.
Nice to meet you. Have a great rest of your day.